Okay. All right. Let's finish up lecturing with this one. For this is the next. This will be in the next test. This is monitoring. Okay. Monitoring is actually people don't talk to you enough about it. At least I feel that you don't get talked about because we get so much other stuff included in what you have to learn. But monitoring is the practical application of what we've just been talking about, which is all the pathophysiology and all the things that you sort of have to pay attention to. Monitoring is something that you really have to pay attention to. Okay? But the most important monitor in the OR is not a machine. It's you. Okay? You're the anesthetist. Okay? You're going to be responsible for interpreting every single data point that's coming at you. And sometimes it's coming at you very quickly and kind of subtly. And if you are a person that cannot process multiple things at the same time, you're going to have a hard time with this job. I can tell you on the first, I don't know, maybe the first 6 weeks, you will be totally overwhelmed. Everybody is. Okay? Anybody who tells you that, oh, this job's easy as soon as you walk in, it feels like, you can do it in your sleep. Not. Okay? The first 6 weeks are a complete nightmare because everything that's coming at you is completely overwhelming you. And everybody's telling you to go faster, faster, think on your feet while you're trying to do one thing or another. Okay? And guess what? The job doesn't get any easier. What it does is that you become accustomed to the stress. But I can tell you that for doing this for 20 years, there's little things that bother me as much as they used to. But when I first started, I had palpitations. I used to worry a lot about that I was missing things, and that makes you sharp. You should never feel like, this job's easy and walk in. If you do, it's time to retire, okay, because you've now become dangerous. Anybody who tells you that this is, you can just sit back and let the machines keep an eye on things, no. They don't do any interpretation. They just feed you data. And data has to go through your ears, through your head, and you've got to process it and figure out what's going on. Okay? So ultimately, you're going to be doing A-lines, you're going to be putting in swans, you're going to be doing spinals, you're going to be intubating people. So you're going to be doing a lot of things at the same time as you have to keep an eye on things. Now, one thing that you have to learn is and you pretty much don't have that problem here or anywhere else in our clinical sites, is that when you start doing a procedure, somebody else is usually watching the monitor. Okay? But when you get into clinical practice, you're usually it. You're it. There's nobody else to watch anything. So you're going to have to learn auditory. They listen, okay, while your equipment is monitoring the patient while you're doing something. So when something goes wrong, you pick up on it right away. If you shut off your auditory information that's coming in, it's very detrimental, okay, in the sense that you will not pick up something that you will pick up almost instantaneously when something changes. Okay? When you do pulse oximetry work, when you actually begin to do this job, you'll go home and when you close your eyes, you'll hear beep, beep, beep. Okay? Don't be worried. It's not like you're going crazy. All of us have gone through that. Okay? And it's a normal process for your brain just to completely repeat the same sound that it's being hearing all the time, especially when you're at rest. What's interesting about it, after about 6 weeks, guess what? You don't dream about it anymore. You don't hear it anymore. It becomes background noise to you. What's really cool about it is you stop it and your head starts swiveling, looking at what the heck happened. There's something wrong. So your brain becomes accustomed to a sound, so much so that you respond as soon as it goes away. The Japanese, before or even during World War II, and even after World War II for many, many years, the way all their homes in those days, up to the 1970s, were mostly paper and wood construction. So you can imagine, and they're using open charcoal for fires. So you can imagine the fear of fire in that kind of culture would be pretty high. And the way they actually manage it is that at nighttime they would have a fireman literally walking around the block looking for fires. And what he would do is he would take a stick, okay, and he would hit the stick together all night long as he's walking around. As soon as he stops hitting the sticks, what would happen? Everybody wakes up instantly. Because they know it's fire. You don't have to yell, you don't have to tell anybody, but it's the same thing that you're doing. You're doing the same concept that was learned many, many hundreds of years ago, okay? That if you give a continuous stimulus, that it will make you monitor more efficiently when it goes away, okay? So don't discount auditory stimulus. It is very, very useful. Monitors basically provide you prompt recognition of adverse events, okay? It gives you more response time to therapeutic intervention, and it can give you ideas if your equipment is working properly, but they don't make up for the lack of vigilance, okay? I personally hate people when I walk in the room that they're reading a magazine. It'll be a terminal event if you work with me, okay? Because if the way I look at it, if you're reading a magazine, you're not paying attention, okay? When I walk in the room, I wish I could take this thing and burn it, okay, my telephone. I hate it because it takes me away from the care of the case, okay? And what ends up happening is, nowadays, if you have a phone on you and something adversely happens to the case, one of the first things that the lawyers pull up is your phone records, of all things, okay? Because you're going to look to find if you were calling or texting or talking to somebody instead of being vigilant and watching the patient. Okay, so just be prepared. So my point is, unless the only time I ever pay attention to this is I look up real quick, make sure that it's nothing serious, and I just close it back down. I do not text in the room if I can avoid it. Okay? Sometimes I can't because I got other things that are important. They have to be taken care of, but still, those are quick, and I keep an eye on what I'm doing. Okay? It's like driving. You cannot take your eyes off the monitor and take your eyes off the patient. You got to stay awake. Okay? So even though your equipment could be all everything working fine, you can't really fall asleep either. Now, all I can tell you is I've been doing this job long enough that I know that I could fall asleep doing this job. Okay? It's easy to fall asleep. You're hearing a continuous sound. There's nothing really going on. The surgeon is quietly working on the other side, and you're sitting there in a possibly comfortable chair, and you can fall asleep very quickly. Okay? So a lot of us, what we'll do is we'll take the chair and kick it back and literally sit back and do nothing. Okay? I've had this to students. What I do is when I walk in the room, I close my eyes and I put my feet up. A lot of students think that I'm asleep. Big mistake. Okay? 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 And I'm like the sleeping lion, okay? I'm not asleep though, okay? I'm listening to what's going on, and I'm actually listening to what the monitors are telling me, okay? And as soon as something changes, you'll see me look up, okay? I'm also resting because I know that I don't have that much time sometimes. That's all the rest I'm going to get. Sit down for 10 minutes and then get back up. If I feel like I'm going to fall asleep, I get back up and do the Irish tap. It's a little bit movement, okay? Make sure everything's still circulating and make sure my brain's getting enough blood flow, okay? So things that you'll learn as tricks. You cannot fall asleep. If you feel like you're falling asleep, then you need to get somebody else in there to get you out, okay? And you tell them, you know what, I need out for 20 minutes, take a power nap, and come back, you're fresh, you're fine, okay? Does this job really let you do that very often? The answer is very much no, okay? Some places can actually and will do that for you, but I'd say that's a really minority. So really important for you to get adequate amounts of sleep. Or like some people like myself, we don't have any more sleep. We get sleep 4 hours a night, and that's all we get. And that's pretty much what I'm accustomed to. And if you do if you do this job long enough, you can do it. And is it good for you? I would say no. It puts a lot more stress on you. So if you are a person that needs 8 hours sleep, then go to sleep early the night before. Now, monitoring was done in the old days without any monitors, without any instruments. The instrument you had was your eyes, your ears, okay, and your palpation. You can actually feel. If you look at the old anesthesia equipment, the biggest innovation was a stopcock, believe it or not. Why a stopcock? Well, because a stopcock, it gives you the ability to switch over your precordial stethoscope to your auscultation stethoscope. That was high tech. Okay? You wouldn't have to switch over your ear from one side of the X. Okay? Because one of the things that we had was we could always hear the person's breath sounds. We would always put a precordial stethoscope. This is before my time, but I was trained with esophageal stethoscopes, and we had to have our earpieces in all the time. Now, because of that, my right ear is deaf. Okay, partially because I've had anesthesia personnel inject propofol in my ear. That was fun. They put it in my stopcock and injected it. They thought it was the IV. So I always got to be careful. Make sure that if you do have a stopcock on your system, make sure no idiot gets hold of your stopcock and injects medicine into your ear. It feels like a real rapid flush, and it makes you kind of deaf for that second, and it kind of hurts. Okay. The other thing that people think it's always funny is a surgeon will say, "Are you listening up there?" And they tap your precordial stethoscope on your metal drum. Yeah, you're there. You know. So I always after a while, I used to keep it a little loose. But when you're doing peds, you're going to have to keep it on, and you pay attention. So anytime you're really ventilating somebody by masking somebody, you really should have your precordial stethoscope all the time on. Okay, so make sure you're fitted properly before you go. Do I still use it as much as I used to? The answer is no, because I walk in and out of rooms. But if I was going back to independent practice where I work by myself, I think I would go back to using it almost all the time. The new thing that people are actually developing, and I've been working on this myself, is a one that's Wi-Fi. Okay, it connects up to your ear, like an earpiece, like we use for cellular phone, and now you have it without any connection. So it's completely wireless. Okay, pretty neat technology. And you can put your precordial on the person's chest. It's a little bit too expensive right now, but the price comes down, it'll be more reasonable. So the other things that you have available besides listening is you should be able to inspect. And by looking at somebody, you can tell their hemoglobin just by looking at them. Okay? The first thing I always look at is people's nails beds. Okay, when they come in, if somebody's hemorrhaging, I look at their nail beds first. If their nail bed is pink and their hands are warm, they're not really in shock at that point. If their hands are cold, and if you look at their nail beds, they're completely white, that person is showing that their hemoglobin's less than 8, okay, or less than 10. Okay, sorry, less than 10. Okay? So when you lose your capillary refill, you're looking at hemoglobins around 10 or less. The next place you look is look at the eyes. Okay? So you open up the eye, they look at the conjunctiva. If the conjunctiva is still pink and looks like it's perfusing adequately, you'll see that that person's range is between 8 to 10. Okay, so it's above 10. As soon as you see the conjunctiva look white, which it will, it's less than 8. Okay? So you see, now I've got you into just looking in. You can tell somebody's hemoglobin just by looking. You already know if somebody's above 10, in between 8 to 10, and less than 8. Okay? And then you'll see the last one, which is what you really don't ever want to see, is you want to look at somebody's tongue. Okay? Normally the tongue is highly perfused. So for that to be showing it turns white, the hemoglobin's less than 6. Usually in deep trouble at that point. Okay? And invariably one of you will come back and tell me, it's usually one per class, usually comes back and tells me, "Dr. Nolan, you're right, the tongue turns white." Yeah, it does turn white. Okay? And usually the hemoglobin is like 4 or 3. Okay, by the time you notice it, it's that severe. Okay. And then keep an eye on the surgical field. Here, listen for suctioning sounds. And usually the surgeon will get really quiet. I always call it the submarine mode. Okay, silent but deadly. Okay, the sucker is going silent on you because he's screwed up and hit one of the major blood vessels, and all of a sudden you're hearing, and you hear him not talking anymore, and he's like concentrating. That's usually really bad. Okay, and you better put your head over the top and see what the heck got hit. Okay, if it's a portal vein, and you got a big trouble. Okay, if it's something less than that, you can handle it. It's fine. If you can't handle it, radio, little help in here, please, and that's it. You don't have to announce to the world, "I got a Dr. So-and-so hit the aorta." No, don't do that, okay? You lose points for that, okay? Yes? You are going to be the one transfusing the blood, but you should never give anybody blood unless you discuss it with the CRNA with you or the MD with you. Most MDs will, when you're working here, you're going to be working with an MD invariably, you should talk to them because that's a pretty high-end decision in the sense that you're increasing the risk tremendously of that patient. And the surgeon, usually the MD will talk to the surgeon at that point to make sure that they understand they're giving blood. So anytime I give blood to somebody, I inform the surgeon I'm going to give blood to this individual, and I give them the reasons why I give it. I don't ever, if a surgeon tells me to give blood and I was a resident, immediately I said, page my attending. Okay? Which is, they come in, You tell them you get blood, and they go, okay, fine, go ahead. You know, but be careful. With some of the surgeons will ask you to give blood to somebody who has a hemoglobin of 10. That's not appropriate. Okay? They don't understand where they're at. They think that they're losing a large amount of blood, and they're actually losing maybe 30 cc's because they've got their spectacles on and everything looks like 10 times bigger than what it should be. Okay? So I'll keep the joke about that one later on. But palpation is the other thing that's important. Skin is important in the sense that you can feel if it's warm or cold. So when I shake people's hands, it sort of tells me if the person is in shock or not. Feeling somebody's pulse takes time. Okay? So you should always feel a pulse on yourself. And it took me a long time to do it, to get really an idea exactly what a pulse feels like. You know, clinically, when people tell you in the book, oh, yeah, it's easy, it's not. It's a certain thing that you got to do over and over again. So the person who suffered from this was my wife, who I constantly would hold her wrist and actually hold her pulse. And I would just check it every once in a while, just to keep my sensory level high and feeling exactly what was going on. Okay? And it gives you, if your spouse is willing to do that, this actually helps you a lot in clinical, believe it or not. It does make a difference, especially when you're putting in A lines and stuff like that. Okay? The other thing that's a little bit strange about pulses are basically can be referred, which means that when you feel the maximum pulse, does not necessarily mean that the artery is right below that. It can be referred off of a shelf. If you look at the radial artery, the anatomy, the radial artery is underneath one of the tendons, or right next to it. Okay? And that tendon acts like a roof over it. Okay? If you were in, let's say, an example would be like if you were in the Pueblo Indians, they would put their houses inside the cliff sides. And if you were walking on the cliff edge on the top, would you hear anything at all? People could be talking below you, couldn't hear a thing. It's really strange. Okay, the only time you could hear people was if you're inside the actual valley below. Okay, that's where the sound would go downwards, but it wouldn't go up, it wouldn't refract up. So you would not be able to hear the people, so it would actually hide them from their enemies. Okay? Well, same thing happens with the radial artery. Okay? When you're feeling it, when it feels maximally impulse to you, it's actually more medial. And that's what happens with most new students. When they're putting an A line in, they'll usually put in too lateral. Okay, and they'll miss it. And they'll go like, I feel it there and I can't hit it. I said, just go 1 millimeter more medial than you think it is. And as soon as you do that, you hit it. Okay? So that's a little gem that wish somebody passed that on to me. Okay? The other thing, you can tell skeletal muscle tone. Percussion, of course, you can hear gastric distension, and you can hear it for pneumothorax. Auscultation, you can hear, of course, lots of things. You can hear murmurs, and of course, you can auscultate for blood pressure. Monitors that we use as routine. Every case should have a non-invasive blood pressure cuff. That's standard for now. Precordial and esophageal stethoscopes are considered standard treatment. The only thing that will replace that possibly would be end-tidal CO2, because both of those indicate that you're breathing. Okay? EKG, everybody should have it. If you're not having a really high-end place, you're using 3-lead, if preferably you're in the hospital or in a day surgery center where you're trying to monitor for any kind of ST segment changes, you need a 5-lead. So if you look in most of our centers, we're using 5 leads. Pulse oximetry, of course, to measure oxygen saturation. Now, disconnect alarms for the ventilator to know if you've got a disconnect in the system, oxygen analyzer, which is your FiO2, and capnography. Of those routine monitors, which is the only one that has reduced the amount of bad outcomes? Yep, capnography. You would think pulse oximetry, a lot of people put that as wrong, but that's the wrong answer. It's capnography is the most important, because that tells you that the tube is in the right hole and that you're breathing in and out. Okay? That's the only monitor that tells you that you're actually breathing. Okay? Common but not routine monitors, I think, to me, I use peripheral nerve stimulator all the time. If I give a muscle relaxant to anybody, which is almost invariably almost every case, I use my nerve stimulator. Even if I'm using something like succinylcholine, which is short acting, I still use my nerve stimulator. Because if what happens if the person has some kind of problem with succinylcholine metabolism, okay, they have an acetylcholinesterase deficiency, then you're not going to pick it up unless you do a twitch monitor. Okay? Tidal volume is invariably in all the machines nowadays. Urine output, sometimes we monitor it, sometimes we don't, depends if we have a Foley. Okay. Body temperature is, I think, is not, believe it or not, is not routine. I think it should be routine. So I put always esophageal stethoscope or skin temperature on every patient because I'm always looking for MH. I've only had 2 cases of MH in my career, and hopefully I'll never have them again. But something you always got to be aware of. ABGs and blood gases and pH to check for if you have anybody in shock or you think that there's a reason to monitor somebody, you put that in. And then a mass spec we do have almost on all our machines, basically, not really a mass spec, but a spec that basically watches the gas concentrations. Invasive monitoring is, I think you should put it in if you think you need it. Okay, that's my only indication I can tell you. Most people, you know, if it's not because of money. If I think that you need it, the way I keep myself honest is what would I do if this was my family? And that's what keeps me, my head straight all the time. I always think that way, okay? And that's the way it keeps people safer, I think, is it personalizes what I'm trying to do. And money never comes into it. If anybody ever says that to me, I get kind of upset. I will do things for different reasons, but the one thing I will not do is do it for money, for making extra money on a patient. Some places will do that, and I find that very objectionable, where they actually put in every single monitor known to mankind for absolutely no reason except that they're getting extra billing. That's nonsense. You're increasing the risk to the patient, and all you're doing is just being stupid. Central nervous system-wise, EEG and somatosensory evoked potentials and motor evoked potentials are the possibilities. And we will talk about those a little later on when we talk about coexisting on neurological diseases. Now, blood pressure is something that kind of occurred when I was a resident, how it's actually monitored. Before that, we were actually using blood pressure cuffs and listening auscultation-wise. So I actually came from the time period where you actually had to listen to the heart and listen to the blood pressure via carotid cuff sounds to be able to get a blood pressure. And then something really came around, which was Criticon. Criticon was the first company, and actually it's located in Tampa, and they use our actual clinical sites as the guinea pigs to develop the non-invasive blood pressure system. Okay? The non-invasive blood pressure system is automatic, which is really nice, so you don't have to worry about it. It gives you a blood pressure every 5 minutes, pretty much. Okay? And you just set it that way, it will give it to you every 5 minutes. Now, if you go back, let's say 50 years ago, okay, even less than that, 30 years ago, okay, and you look at people's anesthesia records, and you'll see that they've got their little things marked off, and it says every 5 minutes that they mark the pressure. BS. That never happened in real reality. Okay, in reality, you did every 8 to 10 minutes. If you were worried about it, if you didn't, you sort of caught up in between, okay, because you were too busy doing other things, okay. So you did the best you could to try to get blood pressures, but the way you did is you listened to the heart with a precordial would tell you the blood pressure. You could actually hear the heart, how well it was pumping, and it would tell you how well the blood pressure is. Once you correlated to the sound to the blood pressure, you knew exactly what the blood pressure is by listening to the heart. As soon as you went going, okay, that means you were in trouble, okay? Because the sound just dropped off. It means that the heart was empty. Okay, and usually that would happen when the aorta was torn or something bad happened. Okay, so you could actually pick it up faster than even a non-invasive blood pressure cuff. Okay, so not that people weren't monitoring; it's just that when people tell you, "Oh yeah, I monitored every 5 minutes," in the old days before I had a non-invasive blood pressure cuff that was automatic. No way, you had no way of doing that. It was not possible. You're not a human being if you are that. Try to get a human being to do something every 5 minutes. Think about that. Try to do that every 5 minutes of something of anything. So, invasive. So, non-invasive machines became better in the sense that we were able to monitor more closely. It doesn't mean that always the things were valued. In other words, in the sense that sometimes the numbers are completely skewed and that are false. It could be the surgeon is up against a non-invasive blood pressure cuff, and then the machine says that the blood pressure is 60. In reality, it's not. When you check for the pulse, it's nice and strong. It's just that the machine is messing up. Okay, so you have to sort of know what how an automated blood pressure cuff works. And I'll talk about that in a minute. And then how it relates to an invasive blood pressure like an A-line. And I'll talk about that next too as well. Indirect-wise, you have end-tidal CO2, which is, believe it or not, it's an indirect measurement of blood pressure. It is a poor man's A-line. Okay? If the CO2 is 34, 34, 34, 34, and the blood pressure is about 120 in the whole correlations, it's pretty much going to stay that way. Okay? As soon as the blood pressure goes down to 80, the CO2 will drop down to 30. Okay? So dropping end-tidal CO2 is indicating decreased perfusion to the lungs, okay? Which means that the blood pressure is also dropping. Okay? Pulse oximetry will also pick it up, but it's a little bit more, the pulse waves will be amplified sometimes by the machines, and sometimes you'll miss it, but you'll hear the tone will actually sometimes change, and then you'll see it be lost in the, when you have a blood pressure of 80 or less, the pulse oximeter will not give you a pulse wave anymore in the hand. You have to put it to the ear. Okay, the ear will still give you a pulse oximeter around 65 of pressures. So now the way a non-invasive works is it basically squeezes your arm and then completely occludes it. Okay. Now there is no sensor that listens to the heart. Okay, it listens to the blood flow to the actual blood vessel. So when you look at a blood pressure cuff and you see that it says should be where the artery is at, that does not apply to a non-invasive blood pressure cuff. That's automatic. It only applies to the person doing carotid cuff signs. If you're doing carotid cuff sounds, you want to have the balloon bladder right next to where the artery is that you're occluding it, because you're actually listening to the difference in sound. But a non-invasive, you could flip it upside down, wrap it, tape it. I don't care what you did with it. As long as the thing is on your arm, it's going to give you a blood pressure reading. Will it be completely accurate? The answer is no. But as long as you have it on the arm and it's not overly big or too small, you should get a good reading. Okay? What it basically does is it doesn't listen, okay? But what it does is it feels pulsations. When you squeeze the arm completely, the pulsations will stop. Okay? So this is carotid cuffs. This is what you're hearing right here is you're listening. Okay? But let's see if I got, yeah, this one. This is what I was talking about. The automated blood pressure cuff will actually sense, okay, when your arterial pulse comes back. Okay? By the actual cuff will actually inflate and go up and down. Okay? This is called the oscillation measurement. And then when it hits the peak oscillation, it usually takes 3 pressures like that are the peak. That calls that the mean. So the initial criticons are actually extremely accurate at systolic and mean arterial pressure. And when it correlated to carotid cuff signs, which is a non-invasive measurement, which is non-automated, it was very accurate. Okay? But the only measurements that we got when we first got the first machine was systolic and mean. There was no diastolic measurement. And most of us said, you can't sell us this. We won't, nobody's going to buy it. If you don't have a diastolic pressure, then I can't put it on my paper, and then it looks bad. It looks like I'm not monitoring. So what they did was they came back about 3 weeks later, and they showed us this machine. This is the actual prototype. Okay, this is what we knew. Almost everybody's done this. Has been doing this for 20 years. Use one of these criticons. These big blue boxes are basically like big bricks. Okay. And in anesthesia machines, what we actually did was we took these guys and put them on top of our anesthesia machines and ran the lines down out of them. Nothing was incorporated in a single monitor. It was just, that was the box. Everybody loved it. Okay? And it relieved us of a lot of workload. Okay? And it gave us more time to think about what we were doing. Okay? And what the machine does is it does mathematically figures out diastolic pressure. So diastolic pressure is completely a figment of our imagination. Okay? It has never been mathematically proven to be correct. No study's ever been done on it, okay, and nobody gives out their data as to what diastolic pressure, how they measure it. In other words, they don't give you the mathematical formula. It's considered a patent. Okay, so you're not able to even look at it scientifically. Okay, but we do know it correlates fairly well. Okay, when we do A-lines, it correlates pretty well. Okay. The good thing about automated blood pressure cuffs, it's a hands-free operation, programmable, adaptable to all ages. Measures mean, systolic, and diastolic pressure, but really measures only 2 of them, mean and systolic. And does function in all extremities, and has a programmable alarms. And guess what we do in anesthesia? Shut them all off. Almost all the alarms, we shut everything off, except for the disconnect alarms and stuff like that. The reason we disconnect is because we're looking at the monitor. We do know we're watching it. Okay, so unless you're walking away, there's no reason to put everything alarms on. Okay, you got to watch every time you should hear this little click click, which means that the blood pressure just took, and look up at your screen. Okay, it's another auditory thing that's coming at you. Okay, and you'll get good at it after a while. Okay, accuracy, mean arterial pressure is the most accurate. Okay, on this machine. Systolic pressure is still pretty accurate, but mean arterial pressure is by far the most accurate. Diastolic pressure, forget about it. It's never completely correlated. Now, if you do an arterial blood pressure from an A line, okay, one of the things that is important is that the arterial blood pressure that's generated in an A line depends on where you put it, okay, and it also depends on the actual pulse wave that bounces off the wall as it gets down to your smaller arteries. Okay? So peripheral vasculature divides, contour size, and character of the arterial pressure wave may vary. But what's interesting is you go away from the aorta, okay? So in other words, from the aortic valve away from it, you will see that your A line, say your blood pressure is here, okay? That's your systolic and that's your diastolic. Okay? As you go away from it, down towards the legs or up to the arm, you will see that your systolic pressure is actually getting higher as you're going further away, and your diastolic pressure is going lower as you're going further away from the aorta. The only thing that's universally the same throughout the whole circulation in the arteries is that the mean arterial pressure is the same. Okay? So one of the things that you'll know is that when you work in a unit, you will invariably have somebody ask you this question. They'll say, your A line doesn't correlate to my non-invasive blood pressure cuff. And my answer to that is it should never correlate. The non-invasive blood pressure cuff is here, and your A line is down here, okay, which is down your radial artery. Okay? So there should be a discrepancy, except for what? What's my first question that I would ask to make sure that the actual value is actually normal? What's the map? What's the mean arterial pressure? If the mean arterial pressure is the same, then that A line is actually accurate. Okay? What you should expect to have is your arterial line should have a higher systolic and a lower diastolic than your non-invasive blood pressure cuff. And that's what you see. Usually it's up to 20 millimeters in difference. Okay? And nothing you can do about it. Okay? Part of the reason I'll show you why in a minute is if it's hyper-resonant. So you can drop the resonance down and eliminate a little bit of it, but it's always the non-invasive blood pressure cuff is going to give you a lower systolic than your radial A line is under normal circumstances. Okay? If you're working with the feet, if you're working with somebody with having an artery down in their feet, which is rare, or you're doing a femoral A line, that also will show a big discrepancy from your non-invasive blood pressure cuff. It'll be much higher systolic and lower diastolic, but the same mean arterial pressure. So the factors that show the wave propagation is basically, this is all part of the A line. So when you see an A line that's generated by the actual heart, which usually looks like this, okay, your dichrotic notch in there, that's not simply just an A line measurement from what is being ejected out of the ventricle. It is also telling you what's going on inside the blood vessel itself. This portion from here to here is the stroke volume. It's what's coming out of the heart. And also it's telling you how compliant the aorta is. How stiff is it? Okay? And then the second portion, which is after the aortic valve closure, that's telling you how healthy the vasculature is in rebounding and maintaining your diastolic pressure. Okay? If you have very thick aorta, where it's basically like a steel package, then when you squeeze into that, it gets you very high systolic pressures, but then it's got nothing to squeeze down on, so your diastolic pressure will fall like a rock. Okay? If you have AI, you will see that the dichrotic notch will disappear because all the volume begins to empty right back into the ventricle. So arterial blood pressure gives you a lot of information, and this is what makes it very complicated. The factors that contribute to the propagation are the energy content imparted by the ventricular systole, which is the heart pumping, the contour transformation of the vascular tree, reflective waves. Also important are dynamic pulsatile flow, acceleration and deceleration of blood, the elasticity, and then modulation of impedance. All these things are important factors in the actual arterial waveform. And as somebody who studied engineering when I was in college, I can tell you I could sit here and talk about each one of these concepts for about 2.5 hours apiece and still not make it clear in your mind as to what I was trying to explain to you. And even I don't understand it completely. So, I mean, and I've been trying to understand this material as best I can because I work with it every day. All I can tell you is that over time you'll get accustomed to looking for certain things on the arterial waveform to tell you the kind of pathophysiology that's taking place. And hopefully this workbook will help you do that. If you look at the one of the things that you've got to really pay attention to is how the A line is set up. Okay? And we spend a lot of time teaching you as nurses how to set these things up properly, but very little time is explained to you how the system is set up as an engineer. Okay? So I would hope that all of you know how to set up an A-line bag, that you have to pressurize it at 300 millimeters of mercury, and that inside down here you have a transducer, which is a whetstone device that takes the signal that's generated from the arterial line, and that pressure transducer then flips it into an electrical circuit, which then makes it into your data stream, which you watch on your monitor. Now, that all being important, what people forget to tell you about is that this tubing is only pressurized at 300 millimeters of mercury when you open up the pigtail. When you pull on that pigtail is when the 300 millimeters of mercury will continuously flow through that circuit and basically flush the line. That's what we call flushing the line. Okay? And when you flush the line, what you'll see on your oscilloscope, on your machine, on your monitor, is you'll see it go up and square off. Okay? What it's squaring off is because it's above the scale where you're working at. Most people have a scale set at 200. So it squares off. Okay? And then when you let go of it, that information of what's happening inside that blood vessel connection with your actual A line is really important. Has anybody taught you that? Some people have knows what impedance is, and in which was called resonance. Yeah. How many people were taught resonance when you're taking care of people in the ICU? Okay, just my point. So, what you should see is when you let go of that. So here you have your standing wave that's staying up top. Okay, that's the 300 millimeters of mercury. When I let go of the flush, okay, which is either pigtail or a squeezy, depending on which one you have, it should fall rapidly down like this and then come back. Okay? That's the way it should look like 99% of the time. That's called a hyper-resonant system. Okay? Which means that you're making, the system that we have is that we make the tubing very thick. So if you take an A-line and bend it, does it ever kink? Very infrequently. You have to really force it to kink it. So A-lines are made extra thick, so the wave that comes at it through the A-line doesn't get dissipated into the environment. It goes directly to the transducer. But they tend to make it too rigid, okay, which makes it hyper-resonant. And when you have a hyper-resonant system, it's like taking a bell and making it a high-quality bell. If you just touch a bell that's good quality, you'll hear it ring multiple times, more than the impact that you hit it with. Okay, it's called hyper-resonance. Okay, or the way you think about it too is you go buy china. Okay, reading the way that good stuff is, you take your finger, wet it, put it on the top, and you hear it ring. That's the good stuff. That's a Waterford crystal or something like that. Okay, that's called hyper-resonance. It's another example of that. Okay, now why is that important? Because that means that whatever pressure wave's hitting that catheter, it's going to give me a hyper-resonant wave. My mean arterial pressure is going to be the same, but my systolic pressure is going to be higher, and my diastolic pressure is going to be lower. Okay? That being said, what happens to, what should you want, Dr. Nolan? What would be a normal, completely normal resonance system? A normal resonance system would look like this. When you let go of it, it goes down like this, bounces twice, and it's done. That would be ideal. Okay, that's called an ideal system. In an ideal system, your blood pressure will pretty much correlate exactly what's going on with a radial A-line. And whatever it is the radial artery is doing, that's what the blood pressure will actually be told on the monitor. Okay? Will it still be higher than the non-invasive blood pressure cuff? Absolutely. In the systolic. Will it be lower than the diastolic? Yes, it will. Okay? So it really mimics what it's supposed to do. Okay? And that's what you really want to do. Now, the other thing that people, every once in a while you get a phone call and say, well, I've got a system that's not giving me a good blood pressure. And I said, did you do a resonance test? And usually you get, huh? Okay. But when you do a resonance test in certain situations and you see the following, okay, that's worrisome. Yes? No, two different things. Well, some people mix it up as two together. So maybe that's what they're teaching you, but really a resonance test is when you let go of it. The square wave test is when it goes up and stays there, and then you let go of it. That means that the measurement is exceeding your pressure measurement. So the square wave is in the top. Okay? It's the last portion of what you would call the square resonance would be the resonance test, which is over here. This portion, this way, is a resonance test. Okay? Dampened. Right. Or will be called hyporesonant. Okay? If you see that if you squeeze the line and it only goes up to 100 and it drops back down, or barely you can see the difference between the A line, and what happens is that's the problem with you didn't do enough pressure on your actual pressure bag. You didn't set it up to 300. You forgot to pressurize it. Or if you didn't, you pressurized it, but you turned the stopcock the wrong way and the air bled out, which happens to all of us, okay? But that's how you figure out. That's part of the square test. The square test just tells you if your pressurized bag is working properly, okay? But the resonance portion, which is when you let go of it, that tells you the integrity of the line, of the A line to the transducer. If you have anything between you and the transducer, like air bubbles, blood clot, a kink catheter from an A line like this, then you'll get a dampened waveform. So there's only three things that would cause a dampened waveform. A kinked A line, okay, which you usually can obviously tell when you look at somebody's arm, they got it like this. Okay, that's obviously telling you the tubing is bent in half. Second reason is the air bubble is a major one. Okay, because in the old days we used to use heparin bags, which we were trying to dissuade people from using heparinization anymore. So we're using only saline bags now. Okay, some places are still using heparin, but you're increasing the risk of that person developing HIT syndrome, which is heparin-induced thrombocytopenia. So we're trying to avoid that, or getting white clot syndrome. So we're just making sure they're pressurized at 300. Okay, and the last reason is that there's a clot. Okay, so the way I deal with this problem is as soon as I see it hyporesonant, what will hyporesonant waveform look like? The A line will be dampened. So when you look at the A line, the systolic pressure will be low, and the diastolic pressure will be higher. Okay, and the mean arterial pressure will be the same. Okay, so the mean arterial pressure is the same no matter what you do. Okay, it's always fine, but really, it really makes a difference in the actual waveform height or the diastolic pressure as well. Does that make sense? Okay. So if I had this dampened waveform, the first thing I would do is I would take the first stopcock, which is nearer to the patient, and turn it and pull out the blood out of it and see if I can get any air bubbles out of it. Then as soon as if I don't get no air bubbles, then I turn the stopcock towards the transducer, and I usually look at the transducer directly because that's where the air bubbles are usually at. I tap the transducer several times, get the air bubbles in, then flush that out through my syringe and get it out of the system, and then reset it up, and it usually works fine after that. Okay. Invariably, 99% of the time, it's usually not a clot. It's usually air. Okay. Because when we use heparin, we used to temperature. What do we do with heparin? Put it in the refrigerator. Well, as soon as you put a bag and put it out from a cold environment to a warm environment, the air comes out of the bag. Okay, and it basically forms air bubbles all the time. It's a real pain. So we're going to stop this. Okay, yes. Just stay with, I'm not going to talk about impedance so much. Let's talk about just resonance and just keep it that. Okay, you're asking a little bit another level question. If you want to, we can sit down and talk about it later. Okay. Pulse oximetry is the last one I'm going to talk about, and then we're going to be done for the day, at least for this section. Pulse oximetry, the way it works is that it actually requires two things. It actually has to measure your pulse. So if you take the pulse oximeter, which invariably drives me crazy, and people squeeze a pulse oximeter because they're going to get a better reading. No, it's not going to work that way. If you squeeze the hand, yes, will the probe get closer together? Yes, and the light will emit? Yes, but it doesn't feel a pulse when you squeeze a finger. Okay, so you don't want to squeeze a finger when you're doing the pulse oximeter. It does not make sense. Okay, so you put your clip on. The clip on has a certain amount of pressure, but the way the machine actually is measuring it is it's actually looking at the thickness of your finger. When the pulse wave comes into it, your finger gets slightly thicker. Okay, so every time your arterial pulse hits you, your finger bounces. If we were actually really looking at ourselves, at our bodies, really carefully to the point of microscopic layers, your skin would literally bounce every time pressure wave hit. Okay, and that bounce is significant enough that the light will be slightly delayed. Okay, so the monitor can actually pick up that slight delay time and know where maximal pulse wave is at. Pretty clever if you think about it. Okay, so the machine requires pulse, first of all. Okay, so what happens to a pulse oximeter when you're on bypass? It doesn't work. Okay, it may give you this pretty crazy number, but it's really a number that's who knows what it is. It's mostly Venus. Okay, so a pulse oximeter to work, it has to know when the arterial pulse is coming in, because that way it only measures the saturation during that cycle, at the peak of the pulse. Because it doesn't want to look at the venous side of it, which is the downside. Okay, so pulse oximetry measures pulse, and then it measures oximetry, which is oxygen levels in your blood. The way it does it is by using a diode. Okay, diode is basically a dual emitting device that puts out two wavelengths of light at 660 and 910 to 940, depending on who you read. And what the machine does is basically at 660, light is absorbed by reduced hemoglobin, and the 910 to 940 range, it's absorbed primarily by oxyhemoglobin. Okay, and it then generates this kind of waveform, and from a computer algorithm inside the machine, it is able to determine what the saturation is. Now, is it completely accurate? The answer is no. Okay, but it's a pretty daggone good monitor. Okay? There's several problems with it, which is if you get something in between the light, okay, that absorbs it at the same frequency, it'll cause you to have problems. So the things like, believe it or not, a red nail bed does not bother you. But if you have a purple or black nail beds, which of course are goths that come in with injuries, was a problem with them. Okay? The way you can overcome it is you take the pulse oximeter and turn it 90 degrees. So now it's not going through the nail bed, but it's actually going through the skin to the lateral aspect of the finger. It'll work then. Because sometimes you don't have the time to take the acetone and remove the fingernail polish because you're in a rush. So it does work if you do it laterally. Okay? The other problem with the pulse oximeter is that your finger is not a square tube. It's not a square ending. If you look at your finger, it's got like a slope at the end of it. Okay? If you take the pulse oximeter and just put it to the end because it slips off because the patient slightly moves while they're sleeping, or the ventilator is moving and their fingers are moving just a little bit, the pulse oximeter just comes off, just a shave off, and then all of a sudden the saturation begins to fall on you to 94, 95%. Because what it's measuring is it's measuring part of the environment saturation. Okay? So it gives you an erroneous reading. So it appears that the person's desaturating, so you start doing all sorts of crazy things, checking out what the heck's going on, and then you find out it's just a pulse oximeter. All you got to do is adjust it, put it on more, and then it's done. All of a sudden the saturation comes back to 99%. You're going, okay, no big deal. Okay, it's called the Plenduff effect. Reflectance oximetry is another thing that can happen. Okay, measure the light reflected off from perfused tissue. This is something we're doing in little kids. We actually take a pulse oximeter, and instead of looking in between two tissue planes, now you're reflecting it off the bone, and then it reflects the wave and comes back. It's pretty accurate. It's got its problems with it. Potential sources of error, of course, are of any kind. Pulse oximeter is nail polish, insufficient signal strength, which in other words it can't measure your pulse, which means you're shocky, noisy signals. Probe motion results in saturation reading of 85%, which is just somebody tapping their fingers, which is something that happens a lot in OB. When you're doing OB, women get a little nervous, so they start tapping their fingers when they're awake from the regional, and then you'll start thinking the person's desaturating. All you got to do is tell them calm down, keep your hands still, and then the saturation comes back up to 100%. Usually you can pick it up on it because when you look at the pulse wave, it's completely erratic. The machine can't measure that. So it really it's a great machine when a person's asleep. The more a person moves, the more artifact there is, the more problems with it is. The other thing that you'll notice is when you give somebody an IV dye, such as carboxyhemoglobin or methemoglobin, which is bad news, those are things that are really true problems. They can get into issues with desaturation that's really true. This is somebody that gets something like the local anesthetic, carbocaine. Okay. Where you also see dyes would be methylene blue when you inject it. That's not really bad in the sense it's not on the hemoglobin, it's only on the plasma. But the saturation will drop abruptly on it, and it'll freak you out the first time you give it. So you're thinking, oh my God, somebody's desaturating like a stone, but in reality it's not a true desaturation because it's not affecting the actual hemoglobin. All you're doing is you're affecting the actual plasma content with pigment, but that doesn't bind to the hemoglobin. This is the actual transducer. This is what we normally think of out of pulse oximetry, and this one is the actual reflectance for the photodetector is right next to the LED. So the LED fires electrical, the two lights, and then it reflects off the cranium, usually off the bone. In kids, it's pretty easy to do because the skin distance between the skin to the bone is small. The bad thing about this is an LED, which is what? It's light-emitting diode, which is it performs heat. So in kids, you'll get burns. You get circular burns if you don't change these out every once in a while. You got to move it around. We used to do this a lot in preemies, and you had to be really, really careful. About every 2 hours, we switched out where the pulse oximeter was, the reflectance pulse oximeter was at. Okay. I think we're running out of time. So limitations is motion. Okay, this is motion artifact you'll see on your machine. Okay, this is noise artifact that also can be a problem. The noise artifact can be actually not from people moving. It actually can be from UV lights. UV lights will fool the pulse oximeter. They'll show you that you're desaturating. The actual waves that come off a UV light, it's not continuous. So it's basically comes out in like waves. And it'll actually mimic it, and it'll look like this kind of sawtooth pattern in your pulse oximeter. The way you get rid of the problem is you take a blue towel, cover your hand, and all of a sudden it goes away. The new pulse oximeters have a new algorithm that basically avoids that problem. But if you work in a place that hasn't replaced their pulse oximeters in the last, say, 8 years, you might still have that problem. And the way you solve it's really easy. You just put a blue towel on your hand, and that's it. This has got to include the air and light. The other thing that gives you true desaturations are carboxyhemoglobin, methemoglobin, fetal hemoglobin. Okay, bilirubin can also, when it's very, very elevated. I've never seen that being too much of a factor most of the time. Jaundice, though, to very severe degrees, can cause the pigmentation, but doesn't really give you a true desaturation. But the pulse oximeter will give you an abnormal value. If you have light interference, which I just talked about, intravascular dyes, which I just talked to you about, fingernail polish, especially in the blues and blacks, electrocautery, which is a big problem. You can see this kind of waveform from low perfusion. MRI is you have to use a specialized pulse oximeter and an MRI scanner, otherwise it goes flying. Not something you want to do. Malposition, which is actually a penumbra effect, which I was explaining before. Sickle cell anemia will also give you problems with readings. Of course, pressure necrosis can occur with pulse oximetry, especially the ones that look like clips. So we've got to be careful with them. Okay? Any questions?